You're listening to Medscape's In Discussion series on psoriasis, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Stephen R. Feldman, Professor of Dermatology, Pathology, and Social Sciences and Health Policy at Wake Forest School of Medicine in Winston-Salem, North Carolina. Relevant disclosures can be found with the episode show notes on medscape.com. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Welcome to Medscape in Discussion. I'm host Dr. Steve Feldman. Today we're talking about the comorbidities of patients with psoriasis and what to do about them. We'll cover how to screen psoriasis patients for arthritis, some of the exciting research going on regarding cardiovascular effects of psoriasis inflammation, and what we need to do to screen for other comorbidities in psoriasis patients. It may not be what you expect. Anyway, we'll get to that shortly. Let me introduce our guest. She's extraordinary. An associate professor of medicine and of epidemiology at the University of Pennsylvania. She specializes in psoriatic and other forms of inflammatory arthritis, is director of the Penn Psoriatic Arthritis and Spondyloarthritis Program, and is deputy director of the Center for Clinical Epidemiology and Biostatistics. I'm so happy to welcome Dr. Alexis Aghdie-Beatty. Thank you so much.
Thanks so much for having me today.
Alexis, you're doing it all, clinic, research. How do you keep it all in balance? Or should I ask, do you have work-life balance?
I know, is balance passable? Maybe I'll throw that question back. But I think balance changes on a regular basis, like every couple of weeks or every couple of months. And so setting the tone for how the next week is going to be is something I try to do over the weekend. And then I try to get all the workouts in and stuff like that, just to kind of maintain my own head level so that I can actually go in with a fresh mind every day. So that's my approach. I'm not sure that it always works, but that's what I try.
Outstanding. All right. Well, let's start with comorbidities of psoriasis. The most common one is psoriatic arthritis, and we'll start with that. I want to know, basic stuff like what screening questions should I be asking patients?
Yeah, that's a great question. So actually, the interesting thing is dermatologists often don't feel comfortable with joints, but a lot of it is actually things that dermatologists are actually the ones picking it up most of the time. And a lot of it's very visual. So dermatologists could be very good at doing the joints with a little kind of training. So what kinds of questions should you be asking your patients? So some of the things are, have you had joint pain or joint swelling? So joint pain is pretty common. Many people have joint pain, but joint swelling, less common. So if you have joint swelling, that's a reason to kind of raise an eyebrow and say, maybe this person should be seeing rheumatology. Also, a lot of people with psoriatic arthritis have morning stiffness. So this is one of the cardinal signs of inflammatory diseases that typically when you wake up in the morning, you feel like it's really hard to move. Now, in patients with osteoarthritis, they experience the same thing, but that tends to go away within a few minutes, maybe 10 to 15 minutes. But in inflammatory arthritis, that tends to last for 30, 45 minutes or more, even, several hours for some people. So if you hear that, that's another symptom that you might refer patients to rheumatology for.
Okay. So my stiffness is probably osteo. That's good to know. Excellent.
Yeah.
All right. Now, the next question I'm sort of afraid to ask because I think I know what you're going to tell me I'm supposed to do, but what physical exam should I do for patients when they say, yeah, I am having joint pain?
Yeah. So, physical examination in rheumatology takes a couple of years as a fellow to get really comfortable with. But what dermatologists are really good at is symmetry. So, if you have a joint that's, you think is swollen, you look at the other side, see is one different from the other. The kind of helpful thing about psoriatic arthritis is it tends to be asymmetric. And so we would expect to see that the patient has kind of swelling in one joint, but not so much in the other. The other thing is just pushing on it. Often there's some squishiness involved in a swollen joint, or you might get a little fluctuation in the knee potentially. In the other joints, there's just kind of this squishy feeling. If it feels bony or hard, that's probably more likely osteoarthritis or kind of more longstanding joint damage. But the squishiness really kind of speaks to active swelling.
Yeah, well, I'm glad you didn't tell me what the last rheumatologist told me, which was, Steve, if they're having joint symptoms, do a complete musculoskeletal exam, including a range of motion and gait. And I'm like, no, I don't think I'm going to do that.
You can send them to us for that. So that's what we should be doing. So,
I think so. I think if the physical exam that these patients should have is a complete musculoskeletal exam, then why do I need to do anything? I just need to hit the referral button.
Yeah. I guess that the one problem with that is if they have joint symptoms and We are obviously very limited. There's actually fewer rheumatologists than dermatologists. And so we have trouble getting everybody in. So anything you can do to help us, especially, kind of pinhole who should be getting through that door faster than someone else, that's helpful.
Excellent. Yeah. So for inflammatory arthritis, get them in quicker because you can help those people. If they've got fibromyalgia, you're not as excited about seeing them.
Yeah, at some point they probably should see us. Some of my colleagues would not necessarily agree to that, but I think everybody should see a rheumatologist once if you have this diagnosis, just to help rule out that it can't be something else.
Oh, that's interesting. So that means I do have to send everybody with joint pain to you, but I don't have to rush them in. All right. Well, I know if we send them to you, you'll take care of their arthritis and treat them appropriately. But is there any psoriatic arthritis treatments that I should be doing, or should I be modifying my psoriasis treatment if they have joint pain?
Yeah, that's a great question too. And sometimes actually the dermatologists are the best position to get that started while they're waiting to come into rheumatology, especially if it's going to be a long wait. And so the one critical thing is whether or not they have axial disease. So if they have inflammatory arthritis, you can probably pick any of your treatments for psoriasis that are systemic treatments, especially the ones that are already approved for psoriatic arthritis, which again is most of them. On the other hand, if they have axial disease, then that modifies the types of treatments that are going to be helpful for them. So for example, it basically pinholes you to a TNF inhibitor or an IL-17 inhibitor. The other therapies don't really have great data for axial disease.
Okay, that raises 2 points. The first one of which is not having data to show that it's effective is to me different from having data to show that it's ineffective.
Yes. And it becomes very confusing when you talk about that. So let's talk about the IL-23 inhibitors for a second. So, obviously you guys use these quite commonly, and there is data. Yeah, exactly. So there's data in ankylosing spondylitis, which is closely related to psoriatic arthritis spine disease. And those, for example, risankizumab and ustekinumab have great negative clinical trials. Like they just didn't really help the axial disease. Guselkumab and ustekinumab have shown in their PSA trials that they improve a patient-reported outcome called the BASDAI, which is supposedly an ankylosing spondylitis measure. There's only one question in the whole survey about spine disease, and it shows that improves. But what I will tell you is that does not necessarily translate to axial disease improvement, and that our axial SPA or ankylosing spondylitis trials are actually a better marker of that. So while I am kind of hedging a little and saying we don't have data, we actually have data in ankylosing spondylitis. It says these drugs don't work there. So until there's a burden of proof on these drugs to prove that they actually work in axial spondyloarthritis, and those trials are ongoing or getting started.
So that takes me back to the screening questions, because we didn't ask back pain. So I'm thinking if I ask patients, are you having any joint pain, joint stiffness, or back pain, it may not be the most specific, but it'll be sensitive.
Yeah. So the reason I didn't bring that up initially is that it's really kind of tricky. So a lot of people have back pain. In fact, 70% of the people you ask have back pain, especially at some point. And then back stiffness, which is a little bit more specific, is not always actually good. So it's not quite that sensitive. So one of the things we do often as rheumatologists is if they're having back pain, we get x-rays of the sacroiliac joints. So the sacroiliac joints, not the lumbar spine, which is where most primary care doctors even go for x-rays. Lumbar spine doesn't tell you anything. It's the sacroiliac joints. And if there's something on the sacroiliac joints, then that suggests axial disease associated with psoriasis. So actually, Joel Gelfand, who's my neighbor in my office and collaborator at Penn, he will often send those x-rays for us in advance because he's an advanced dermatologist with musculoskeletal training from next door. So he will send that. And if there's an abnormality, then he might kind of get us involved before selecting a therapy. So that's something to think about. Although it's hard to recommend all dermatologists do that because, it's not quite so clear even for rheumatologists sometimes.
And that brings us to about referring. Do you have any specific guidelines on who you want referred?
Patients who have active joint swelling or they're really uncomfortable, for example, and they're having axial or back pain, back symptoms that are pretty bad meaning they're affecting their ADLs. But joint swelling, we want to see ASAP. And dactylitis, which is swelling of an entire digit like a big sausage, we want to see those guys ASAP too, so we can help sort things out and get treatment started because they may be more likely to progress more quickly. So I think that's the first people to get in the door. And then if you're wondering, is this osteoarthritis? Is this psoriatic arthritis? We need help deciding on a treatment. those are the other people that we probably should see sooner than later.
What lab test would you like to have when you're seeing the patient?
Yeah, so we've kind of worked this out with our dermatologists too. So we have our set, and our set includes just this complete metabolic panel and a CBC. So we have baselines, C-reactive protein, which actually isn't that helpful in differentiating who has a disease versus who doesn't have the disease, but it's helpful to follow if it's elevated. And then a quantiferin gold, because we're probably going to be starting a therapy that requires that. And then you could consider hepatitis B, hepatitis C serologies, basically the usual stuff that you guys would get before starting a biologic therapy too.
That's excellent. Okay, I think we've covered psoriatic arthritis from beginning to end. Let's talk now about Joel Gelfand's work on cardiovascular comorbidity. Y'all been doing amazing work at Penn on that. I think that may be, if not the hottest, certainly some of the hottest research going on in the world of dermatology.
Cool. Yeah, no, it's been really fun. And we have a new study we're getting off the ground here to look at how to make this practical for screening in clinical practice.
Excellent. So it sounds like you think there should be some screening.
I do think there should be screening. I actually screen almost all my patients. I have that as a part of my plan for every patient. I can remove it if I want, but it's always there so that I think about it. If it's in my template, then I know I'm going to at least think about it or ask about when they had their lipids done, if they had a hemoglobin A1C screening, and I throw those in with the labs once a year if they have if they have not had those done with their primary care physician.
So you're getting just the standard age-appropriate screening test that their primary care doctor might have gotten anyway. You're not recommending additional screening beyond what would be standard and age-appropriate for people?
Exactly. So I try to get lipids and hemoglobin A1C for everybody at some point, but I don't necessarily have to get them if the primary care has done them. I will say that, 30 to 50% of my patients aren't really seeing a primary care physician. And I don't know what that's like in dermatology. We have a lot of patients who, they think the specialist is good enough. I'm seeing the specialist all the time. I might as well just stick with that. So if someone has a good primary care doctor where I know that they're doing the follow-up, then I say defer to primary care.
I get on my high horse when I hear people tell me, well, there's an elevated risk of something, we need to screen for it. And I wonder, unless there's a really strong reason to screen, should we really be screening? I'm old. They checked my cholesterol. It's high, and they say, go on a statin, you'll reduce your risk by like 30%. I'm like, wow, that sounds like a lot, until you realize my baseline risk is for an event over, the next 10 or 20 years is 7%, and a 30% reduction of 7 is down to 5. So I take a pill every day to go from 7 to 5. I'm like, is that clinically meaningful?
Yeah. Well, first of all, 7% would be on the border where you may or may not actually do that. But so it's usually in those people who are going to have a little bit higher risk than that, 10% or more the next 5 years, you're going to want to start on a statin. So I guess from a holistic point of view, and maybe this is the rheumatologist in me, but, we're thinking about the whole patient sitting in front of us, and I'm treating one disease, but that disease is closely linked with a bunch of other things, including obesity and metabolic disease. And I know that if I treat their obesity, if I could get them to lose weight, I could get them to respond better to their therapy. Their disease would be less impactful. They'd have better quality of life. So, there's so many other benefits to this. And then for the lipids, it's an opportunity for engagement on that topic. Like, metabolic disease has really significant impact on your quality of life. Not to mention, if you have a heart attack, that's going to absolutely change your life. So I think that it's how bad the outcome is if you have that outcome. Of course, it is rare, but if you think even about COVID vaccination, we're pushing that hardcore, and you're talking about risks for death that are lower than what we're talking about for cardiovascular disease, which is, number one killer of people. So I think that it's really important to address it and to have an entry. And so we might not always be the one that starts the statin. We're often not going to be the people starting the statin, but at least we're laying a foundation for this is really important for your overall health. Your disease is one piece that I'm treating is one piece of your health, but your overall health is what gets you through the day and gets you through the next 10 years. So let's think how we can make you healthier overall in 10 years. And I think that's an opportunity that we have as their care providers to kind of help them think about that.
Excellent. I was reading that you've started to incorporate behavioral economic tools into your research, and I would love to hear more about that.
Yeah. So one of the things that we have been focusing on is this holistic, healthy lifestyle kind of piece of psoriatic disease. And again, the reason is most of our patients are obese. So we deal with a patient population that is more obese than patients with psoriasis, more obese than patients with RA, and certainly more obese than patients in the general population. And we know that obesity has significant impacts on patients' function and how well their drugs work. So we end up cycling through drugs with some of these patients just because we can't get their disease under control. So we wanted to think about, how do you get them better? And so we already know that lifestyle interventions are things that people do not line up for. No one really wants to go on the diet. No one really wants to work on weight loss. They just want it to happen. And they'd love to have a drug that if you just give it to them, it magically makes it all better. So how do you make lifestyle interventions easier? So this is where behavioral economics comes in, is it, there's a variety of different strategies to make things easier. Some of those are changing your status quo. Examples of that are in prescribe, even as prescribers, we have a status quo. We pick the first one on the list when we put in a medication, but that first one on the list may be a brand name medication. And if we ordered a generic, we'd be saving the whole health system some money. But if you reverse the order of them, people will just pick the first one still. And so then you can decrease costs to the whole health system by changing the status quo.
You might even have that first one pre-checked so that they would have to uncheck it to make them work to choose something more expensive.
Exactly. So if you have some defaults, so defaults are another way to do that. And if you think about all the competing things that people are thinking about on a day-to-day basis, especially now, it just is hard to make any of these things stick. So anything we can do to make it easier for them is helpful.
Yeah, I think thinking about, when you say all the things people are thinking about, I think we do a lot of stuff without thinking.
Exactly. Actually, that was one of the main concepts behind behavioral economics, is that there's two parts of the brain. There's the kind of automatic emotional part. Like you drive to work every day. You actually don't think about all the things you see on your way to work because that's just your route. You just go. And then there's this analytical side, but it's really hard to use the analytical side. And so we have to force ourselves over there. So anything you can do to signpost along the way in the more emotional or, help with driving your kind of automaticity can help a lot with changing some of these things. And that's where changing the defaults or changing the status quo can really help.
Outstanding. All right. As we wrap up, tell me one thing you really want to pass on to listeners before I let you go.
Yeah, I think that for dermatologists to just ask questions about the PSA or even have a handout for patients about psoriatic arthritis so that they're aware of it. You don't even have to do the work. If they just know it can be associated, then they don't know to ask and they can go to their primary care doctor or they can seek out rheumatology. And same thing with cardiovascular disease. If they know there's an association, even if you're not the one sending the lipids, they can go ask their primary care doctor about it. So I think having these things on patients' minds, or at least helping patients understand the link, is really helpful for improving outcomes.
All right. Well, I will recommit myself. Hopefully listeners will too. When we see patients with psoriasis, ask them if they're having psoriatic arthritis. I think asking about the joint pain, the stiffness, back pain, swellings would be good. Making sure they're aware of cardiovascular disease. Maybe if they keep hearing the message, they'll live a healthier lifestyle. Alexis, thank you so much for your time today. It's really a pleasure seeing you and talking with you.
Thanks so much for having me, Dave. It was great talking to you too.
Thanks for listening to Medscape's In Discussion Psoriasis podcast series with our host, Dr. Stephen Feldman. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com for show notes, links, and more information on psoriasis.